Figure it out.
Perfect. Take your time.
Share screen. Oh, here we go. Is that coming through?
It is.
Okay, very good. And then I guess I'll get started. Thank you guys for having me. It's been maybe a decade or so since I've been with you guys, and I'm glad to be here again. What I was going to talk about today, so I was just going to kind of explain neuropsychological assessment, and just talk about the purpose, what we use and what we're doing, what it looks like and what it entails, and then also, sort of how to understand the results that you ultimately will see in a report at the end of the assessment. One of the things we do is we really try to focus on using the assessment to help us to develop a treatment plan for the individual who we're assessing, right? So I'm going to try to, I'll be talking about assessment, especially as used to create a full program of intervention for someone, okay? Okay, and please stop me at any point if anyone has a question or anything as we go. So when we're doing a neuropsycho, when we receive a referral or to do a neuropsychological evaluation on a person, what we're trying to do is understand any and all sources of ongoing problems, right? So, someone may be having some difficulty in school. We want to understand what are the sources of that. There may be some behavioral problems or behavioral concerns, and we want to understand what might be the sources of those, or problems in getting along with their friends or getting along at home or getting along in school. And we want to understand what are the sources of that. It will also, in addition, involve, trying to understand any and all problems that are occurring in someone's life. In addition to understanding the sources of those, we want to know what are the problems. Are there problems with behavioral control, learning concerns? Is the person experiencing distress? So things like that. And then we identify those, try to understand the reason. And sometimes we'll do neuropsychological evaluations to try to contribute to the understanding of any neurological concerns that we might be seeing, and that especially sometimes when we're doing assessments for folks who may have Sturge-Weber syndrome, for instance. And again, the point of the assessment is not only to understand the sources, but to come up with strategies to treat the problems, right, and to improve the problems. So in addition to that, so one of the ways we do that is we try to fully understand someone's neurocognitive function. When I say neurocognitive, I'm talking about their global cognitive, their intellect, right, and also their language processing, their learning. Are there any learning concerns? Their motor functions. We want to know how are they getting along in communicating with others, and how are they doing socially? And then identify any attention or behavioral control concerns. And then again, we really want to know what are the things in their lives that might be contributing to those problems. And then finally, sometimes part of the assessment will involve very fine-grained analysis of some behavioral concerns. What are the problems? What are the specific targets? What are the specific concerns that we want to address? And we might find those residing within the child, for instance, some behavioral problems, but we also might find something, some concerns in the child's life that also need to be addressed as part of their treatment. And then again, at the end of it, we seek to come up with a full program of intervention to address any and all the sources that we find. Neuropsychological evaluations generally, and specifically with us, will involve a number of different appointments. So the first thing we're going to do with a family or an individual who's going to have a neuropsychological evaluation is we're going to go through their history. So we're going to want to know all about their, were they, for instance, born full term, or was there any prematurity? What was their birth weight? Were there any concerns early in the person's life, right? Anything that could contribute to the problems that we're seeing now. We want a full developmental history. At what age, when did someone start to walk? What was the trajectory of their development over time, including their motor functioning? When did they walk? When did they crawl? When did they walk? What are their gross motor skills now? When did language first emerge? And what does language look like now? We're also going to go through their medical history. Are there medical concerns that could contribute to the problems? For instance, someone who might have diabetes could contribute in a number of ways. One being it's very stressful to have a problem like that. Is there any history of seizures, any ongoing seizures, things like that might be contributing to some of the things that we may find. We're going to then go through, the family history, any history of any developmental concerns on either side of the family, any, psychiatric concerns, for instance, anyone in the family have attention deficit concerns, any history about any other concerns that might be relevant. And then we're going to go through, a complete social history. Who does the person live with, and who have they lived with, and what's their family life looked like over time? What are the concerns now, that might in the home, any concerns in the home, any concerns in the child's life that might be contributing to the current problems? Has there been any changes in the family over time? Any major, extremely stressful or chronically stressful conditions, having a caregiver who has an illness, for instance, can be a very important concern that we should be aware of when we're trying to understand problems in living. And then we will go, we go in very in depth through the academic history, right? Any history of problems in learning and across any of the years that the individual has been in school. What have teachers thought those problems might be related to? What are any behavioral concerns in school? Any trouble sustaining attention in class? Things like that. We also will go through what someone's social functioning looks like. How are they getting along with folks, at home? How are they getting along with their peers? How are they getting along in school or at work? For adults, we're also going to, go through their occupational history. Where are you working now? How is your work? How are you enjoying that work? Any problems at work? And just sort of, again, the trajectory of each of those domains over time. And then we're going to look at any concerns with, any aspect of behavior or any socio-emotional concerns. And then we want to know, what's their adaptive behavioral functioning. When I say that, I mean, how are they communicating effectively with others? Are they getting along in the world with their friends, with others at home, in school, at work, etc. What does their motor skills look like? So we want a full understanding of each of those areas in order to help us determine what we need to figure out as we go forward. So usually what we'll do, we start with an intake and we'll garner all that information, and then we'll understand, okay, we need to, do, in some cases we would say, what, I've gone through the history, maybe we don't need to do an assessment. Maybe assessment's not necessary here. But in a lot of cases, And we might say, you know, rather than do an assessment, let's get some treatment going here. Let's get these services set up. But in many cases, we'll say, you know what, let's get a better understanding of what's going on here. Let's get a full characterization of someone's intellect. You know, we want to understand their language. And so we'll use a battery of tests to really get a fine-grained understanding of all the aspects of their neurocognitive functioning. It isn't unusual either. Sometimes we'll do some screening measures at an intake. We might look at someone's social communication skills, for instance, in a little bit more depth, try and understand, hey, maybe we need to rule out an autism spectrum problem here. Or maybe, you know, we need to make sure, you know, be careful to make sure we can rule out an attention deficit concern, things like that. Let's see. So yeah, it's basically to aid us, to get us down the road and tell us what we need to do next so that we can fully understand all the sources of concerns. Okay, in those cases where we're going to test, one of the things we're going to do is we're going to measure someone's intellect. And usually our goal in this case, our main goal tends to be, is there any concern with global intellectual functioning or global cognitive functioning? So a lot of times, for instance, we might be working with someone who's having trouble learning at school, right? And they, you know, the teachers and may suspect, for instance, an attention deficit problem. Well, the first thing we want to know is, but is there any cognitive concern? You know, for instance, the person is achieving at a level below where we expect them to achieve. So, you know, we might, like, for instance, in the case of an attention problem, it could be the case that it's not really the attention, but there might be a global cognitive, an intellectual concern that, you know, looks like an attention deficit problem. So we're going to want to know, is there any intellectual, any concern with any aspect of intellect? And first, is there a global cognitive problem? We also can get a look at cognitive strengths and weaknesses, which sometimes can be pretty useful. For instance, in a situation like where someone has Sturge-Weber syndrome, we can learn, you know, especially when the problem is unilateral, sometimes we can learn a little bit about the level of reorganization that we're seeing, or we can identify certain patterns of cognition that will help us better understand what's going on and provide us some information about how things might look moving forward and what are some of the things we need to be doing to contribute to us, you know, more successful outcome. Let's see. I don't want to belabor this too much. A lot of times I also kind of want to make this useful for when you're seeing a report, right? That depicts the results, and usually they're presenting the data in standardized fashion, right? So like for standard scores, you're going to have a mean in the average of the population. And it's just a way to understand the numbers, so that the average would be 100, and then the standard deviation from that is 15. So here we would call an impairment. So a lot of times you'll read in a report the words normative impairment or normative weakness. And what that's referring to is something that is more than one of those standard, more than 15 points below the mean of a standard score. So we'd be interested in scores, for instance, that would be below 80 as an absolute impairment, but we also will compare someone's numbers to their own scores. So someone who has, you know, a verbal comprehensional index or standard score of 100, will compare a lot of, or a nonverbal reasoning score of 100, a perceptual organizational index of 100. We might compare a lot of their scores on other measures to that number. So someone who has, for instance, a nonverbal reasoning score of 100 That's a very normal nonverbal, it's a score well within normal limits, right? But then we might see language scores less than 80 or less than 70. That's an area of normative and also relative. It's much lower than we would expect given their nonverbal score. There's also sometimes scores are presented by T-scores where the average would be 50 and the standard deviation would be 10. In that case, we're going to be very interested in scores less than like 35, right? To depict an absolute impairment. Again, I don't want to talk too much about that, but it's just a way to sort of understand the scores. So usually we're very, very interested in at first getting a measure of intellect and determining whether there's any concern around global intellect. And sometimes we'll also be interested in the pattern of those intellectual scores. Then we're going to do a full, an evaluation of someone's language function, speech and language function. So any concerns with articulation or speech sounds, any concerns with their understanding of language. So we'll assess how well they're understanding language, including complex language. So we'll look at vocabulary and also language processing. Same thing with expressive language scores. And what we're interested in doing, are those scores consistent with their global intellect? In some cases that, they won't be. And in those cases, we're going to be concerned about a language disorder. It's very important to understand when there's a language problem, especially in the context of typical levels of intellect. Many cases, probably the most common thing that I see in cases where folks are concerned with an attention deficit problem is that there's a language problem. They can look very similar. So you'll have, teachers will be saying, well, he just doesn't seem to be paying attention well, doesn't seem to follow instruction well, things like that. So we want to assess language to make sure before we start treating someone with stimulants, for instance, that it's not a language problem. We also want full assessment of their learning, right? So we want to understand how they're functioning in reading, are they understanding what they read? How's their mathematics skills? How's their writing skills? Again, a lot of times we will see children and there's concern again with like some aspect of maybe behavior in school. The child can get very distressed or not want to do some learning tasks. They may also be, described as getting upset when they're having trouble with learning tasks, or maybe acting out some in school, or maybe described as, again, not paying attention in school. A lot of times what we can find is, okay, global intellect is okay, language processing is good, but they may have a problem in some area of learning, in which can be very distressing to them. So they wouldn't want to pay attention to the tasks, or they may have developed some behavioral adaptations to the situation, right? So they may not want to do the tasks. The tasks are distressing to them. And in those cases, it's very important that we get them supports to help them feel better about learning, so that we can start to attempt to remediate the skill deficits. Again, it wouldn't be very useful so someone who has a reading problem and they're reluctant to do tasks or resistant to doing tasks or inattentive because they have a learning problem, it wouldn't be very effective to treat them with stimulants, right? We would want to get them supports for learning. Also, in some cases, we're going to be doing assessment of memory. We want to look and see, is there any concerns around any aspect of verbal memory, visual memory, short-term and more. So we're looking at more long-term memory and also short-term and working memory. And we want to assess their capacity, their their ability or their current, functioning in being able to sustain attention over time and across tasks? Is there any behavioral control problem? Overactivity, impulsivity, things like that. And then we're going to use some tasks to get a really good understanding of their fine motor skills. Because again, sometimes we might find a child is having trouble with writing tasks. We can assess some aspects of their understanding of writing, spelling, for instance, doesn't seem to be a problem. Sometimes that can involve a motor function. Sometimes we'll see individual may have trouble with their speed. They may be working slowly. Their speed of processing may be low. Some cases we might find that at least part of that is a motor problem. So we want to understand that better. Part of the assessment will very often include parent ratings of different aspects of their child's functioning. So we're going to want to understand, are there any areas of behavior that are at a clinical level, at a problem level? We'll try to understand some of the aspects of a child's executive functions from the parent's perspective as well. Also, we'll get a full understanding of where they're at across adaptive behavior as well. It is very useful as well. Sometimes we want to get an understanding of some other folks' perception of the problems too. For instance, teachers. We're going to want to have teachers rate their behavior across those dimensions as well. In some situations, we're going to want to do some very specific observations of a child's behavior with certain types of concerns in mind. So for instance, we may do some assessment around their social communication skills or their social reciprocity and use very specific measures like an ADOS for that. And that's just at some point we want to, again, we want to have a diagnostic formulation at the end of our assessment as well as we can, in addition, to help other folks who are working with the family as well. Sometimes that we can assess aspects of personality in older children and adults. And there are some cases where we might even do some more in-depth, some personality assessments, much rarer in our practice or in the work that I do, but we might do some projective assessment just to also get some additional understanding of personality concerns. And basically what we're doing is with those measures is we're getting some ideas. Are there any internalizing behavioral concerns? Is there any distress that we need to be aware of? Is the child worrying? Is the child becoming distressed in certain aspects of their experience? Are they tension? Are they ruminating about problems? Things like that. Want to get a full understanding of any social communication concerns, any kind of difficulties navigating or understanding the social world that might contribute to the problems. And then we want to, are there externalizing behaviors? Is there any kind of rule breaking or conduct problems, behavioral control problems, those kind of things. And again, the reason we're using all these different tools is to get a full picture of all the potential concerns that are occurring, and then get some understanding of what the sources of those are. Ooh, I don't want to really do this that much. Again, this slide is really just to assist in understanding what the numbers mean that you see in a report. So hopefully everybody can get a copy of this and just sort of keep it as a guide. But so for standard scores, the average is 100, the standard deviation is 15 of the normative sample, the sample that we're comparing these scores to. And that just shows absolute impairment just means an impairment relative to their same age peers. And a relative impairment is a discrepancy from some aspect of either their global intellect, like their full scale IQ, or like a nonverbal IQ. And then there's also sometimes the scores will be in T-scores, sometimes they'll be in scaled scores. T-score is a mean of 50 and a standard deviation of 10, and scaled score is a mean of 10 and a standard deviation of 3. And standard deviation just says scores outside that range are those we would be concerned with. You know, one of the most, let me see what's on my next slide. Yeah, okay. I'll move on here. So now we have at the end, so we've now done an intake and we have a really full understanding of what the individual's life looks like. We have now used our tools and we have good understanding of many aspects of their neurocognitive behavioral functioning. So now we want to put all that information together and sort of understand what are the problems and what are the sources of those problems. The first and one of the most underrated and underappreciated parts of a report, but one that is really, really important to pay attention to, is the part in a report called the behavioral observations. And the reason that's so important is because it tells us how reliable the assessment data are, right? So is the assessment reliable? Did we get a good picture of how the child is presently functioning in the world? Many of the things, some of the problems that will precipitate an assessment are some of the same problems that can interfere with the reliability of an assessment. So a child who's having trouble understanding language will have some difficulties in some aspects of an assessment because of that language problem. A child who is having trouble sustaining attention may have trouble sustaining attention during the assessment. And those, to the degree that those are true, it's very important to understand because it limits the ability of our tools to accurately describe the individual, right? And limits our ability to make definitive conclusions. So it's very important to understand what happened, what were things like when we were doing the assessment. Was the person able to understand the instructions? Was the person trying? Was the person engaging with the examiner effectively? Was the person able to sit, sort of sit in their seat, and attend to the task? Or were there things that did interfere? And what did we do when we had, so maybe the child was inattentive. Were we able to manage the situation to the point where we could still get accurate data by working with the child, so things like that. It's really important to understand. And at the end of that section, there usually be a comment that says something like, well, we think we got a really good, accurate depiction of the child's current level of functioning, right? In some cases, it might say, well, given that there was some difficulties with language and some difficulties understanding instructions and also some inattention, these data may underestimate some areas of this child's abilities or this person's abilities, and we need to interpret the data cautiously, right? And in some cases, there might have been things going on during the assessment where that very much will limit our understanding, and we'll need to do some treatment before we're able to get a full and accurate understanding of the child or person. So that's a very important part of the assessment, and one that I think should always be read, quick, early and as you go through the report. Okay, so let's say we get through, we say, you know what, I think we got a pretty good evaluation here. It's pretty reliable. I think, there were some concerns that may have interfered some, but I think we got a good picture. And then so the first thing we're going to do is we're going to go to Intellect. Is there any evidence of a global cognitive problem? Um, you know, and how confident are we in making that determination, right? In I would say in probably, you know, 90% of the cases, we're able to get a very, very good picture of intellect. We're able to say, you know what, I don't think the problem here is cognition. We might see some pattern of strengths or weaknesses that is important. We might see, you know, while the nonverbal, you know, person's nonverbal reasoning is strong, well within normal limits, but they're, you know, the verbal reasoning is down, or we might see that working memory is down, or we might see that processing speed is slower. So we're going to go through that and we're going to understand, okay, now, you know, we know there is no cognitive problem, or there is a cognitive problem. That could be one source, and then we'll go to the rest of the findings, or you know what, cognition is fine. The problem is not one of global cognition. After we go through that, the next thing we'll look at is language. Are there any language problems? And then we'll go to learning. So cognition looks good, language looks good. Now we're going to go to learning. Is there a learning problem? Okay, learning looks good. Then we'll move on to attentional concerns, motor concerns. In some cases, we're going to, you know, in some cases, particularly we're looking at maybe pre-surgical evaluations or something like that. We're going to be looking at, you know, is there functional impairment that potentially related to the lesion profile that we see, things like that. Once we understand the neurocognitive profile, we have a very good understanding of some aspects. You know, we're close to conclusions now, but we're also going to add the behavioral components. Is there, you know, any diagnostic concern here? Is there an autism spectrum problem, a social communication problem? Is there an anxiety disorder, adjustment? You know, very commonly we are identifying stress response problems as the source of somebody's problems in living. Okay, so now we're able to have full understanding of the problems, and now we have a very good understanding of what the sources of those problems might be. So we're going to combine the data and develop ideas about now we know what all the problems are, right? So we'd say we have a child with a language disorder. We find we've understand cognition is fine, verbal reasoning is down, language processing scores are down, their learning is down, and has some trouble sustaining attention, but we also know that socially this child is doing well. There's not an autism spectrum problem, not a social communication concern. We also know that there's no stress response problem. And, you know, so we have a pretty good bead, and we're able to, on what the problems are, and we are able to develop now a program of intervention. So for a child with a language problem, we're going to want, you know, a lot of times when there's a language problem, you also will see some difficulties in school. They'll have trouble with learning, not because they have a learning problem, but because they have they're not understanding. And so we can set up, you know, we would directly assess the language through speech therapy in and out of school. At school, we would probably also add some resource room services to try to bolster their learning while we solve the language problem, right? And then there may be some accommodations that we need. It's not uncommon at all for a child who's having language concerns to not be paying, you know, attention well at school, not necessarily because they have an attention deficit, but maybe they don't understand information. If you don't understand information, you will not pay attention to it, right? So like if I'm speaking Spanish now and the listeners don't understand Spanish, you'll stop listening in 1 minute, not because you have an attention problem, but because you don't understand what I'm saying, you know, so I hope that makes sense. In some cases, we will find multiple sources for problems. So let's say we have a child and the concern has been, you know, they're struggling in school and they're struggling socially. And we find that they do have a language problem, which can also contribute to someone's social, you know, social relating concerns, right? Someone who's having trouble understanding or expressing themselves may have trouble engaging with their peers effectively. But let's say that we've discovered a language problem. We're also a little bit concerned about attention. We think it's mostly the language problem, but there's an attentional concern as well. We want to, you know, we want to make sure we address both sides. It's possible to have a language disorder and have an attention deficit condition. The child is also maybe struggling in learning, mostly due to the language, you know, and potentially attention problems. In some cases, we might also find, you know, maybe there's a situation in the child's life at home. Maybe there's a caregiver that has a chronic illness, or, you know, some extreme stress at home, or chronic stressor at home that might also contribute to the inattention and their struggles both socially and academically. So we would also want to, so now we're discovering all the sources, and then we'll put together a program of intervention that addresses all those sources. Now, staying with that same person, so a person with a language problem, also inattentive, struggling with learning, and, you know, also has some stressful circumstances that are contributing to the problems. We're going to have to, some of the things are not going to be perfectly clear. Our conclusions are not perfect. So we're going to say, you know, we think this is a language problem, but we also can't be certain if there's an attention problem. We're going to say there is, right? And we have evidence for both, but it is possible that the attention problem might be more the result of the language concerns, or more consequence of the language concerns, or an adaptation to the language concerns. And inattention could also be, you know, the child is having some stress response concerns and some anxiety, which could further contribute to inattention, right? So we're, at the end of the day, we're going to, at the end of, while we're writing the report, we're going to have to keep all those things in mind. We think this is more language, but these other concerns are here as well. We need to treat them all. And then we should reassess the person in a year. So let's get a full program of treatment that addresses all the sources and then assess again. So for instance, let's say over the course of a year and with the appropriate treatment, now we've improved language. Do we still have concerns around inattention? You know, let's say we've also solved, we got some help around the issues at home and have solved that. Are we still seeing inattention? You know, so sometimes our conclusions allow us to set up a program of intervention right now, but it won't have complete certainty as to all the sources of the problem. So we'll address them all and then look again, and then we probably capture better diagnostic clarity, if that makes sense. Okay, I did want to talk about the, you know, how we set up the treatment program. And so what we do is we're going to use aspects of both the private world, so private interventions, those that like in a hospital setting, you know, outside of school, but we're also going to use the school as well when we're developing a program of intervention. So at school, actually, I'm seeing that I have it wrong on the slide, so kind of switch that. But at school, so I'll stay with the child with the language concern. So we're gonna want that child to have an individualized educational program. I wrote up here IEP versus 504. So if there's things going on in the child's world, like a language problem that is interfering with their ability to achieve to their maximum potential, right, we're going to want an IEP. And as part of that program, we will want to have resources and services in the setting that addresses each of the sources that we're seeing. So for the child I've been describing with a language problem, we're going to want speech therapy. Because the child is also struggling with learning, we're going to want some kind of resource setting to address and bolster the learning while we also work on the language. If there's any motor concern, we would also want occupational therapy services. We may want physical therapy services. We may want, if there's behavioral concerns or any aspect of behavioral social concerns that are interfering with their achieving to their potential, we would want, social work services to address behavioral concerns and also social skill. And then we would want, accommodations that make sense. Somebody who has motor function problems with fine motor skills and trouble handwriting, for instance, we're going to want them to have the ability to use text to speech or dictation services, extended time on things, tasks and tests. Someone with attention problems, we would further want, testing in a reduced distraction setting. I think an accommodation, I should just mention that I often want for children that are struggling is testing supervision. So I don't want them, a lot of times if someone's not fully understanding or having trouble attending or having some behavioral concerns, if we just hand them a test and walk away, they're probably unlikely to give us their best performance. So things like that. So we're going to want all those kind of things. In some cases, we're going to want paraprofessional assistance. I think one of the worst things that can happen in school, especially for a child who's having a language or a learning problem, is, where they're just given assignments or information and they don't understand it, or they don't understand what they're supposed to do. They may not have understood the instructions or the task, and they're just don't know what to do. And in those, that's never healthy, and it's can create problematic adaptations in this, around academic tasks. So, we would sometimes want paraprofessional assistance check in, make sure that the child is attending to, understanding, and engaging with the materials as we expect. It isn't sometimes, I have the word gifted in there too, and sometimes there can be circumstances where a child may be functioning at a level that's advanced relative to their peers, which can also, I see this from time to time, that can also create problems because they may be being asked to work on material that they have mastered, maybe years ago, and they're asked to work on that over time, and it can create, things like inattention or behavioral concerns. So anyway, so we're going to use aspects of the school setting to address any and all skills deficits, and also to provide any supports that are relevant in the school setting. And then we'll also use aspects of the world outside of school to address sources as well. So, staying with the language child with the language concerns, I'm going to want speech therapy outside of school, and if we're also seeing motor concerns, we're going to want, OT, PT, or whatever relevant services outside of school as well. One of the things when I work with families who have someone who has Sturge-Weber, I've always put this in my reports, is I want the most aggressive program that we can get, even in situations sometimes when I'm not finding deficits, right? And the reason is I want to continue to promote reorganization, right? So oftentimes we'll put a statement in, hey, we want, despite the presence of most of these scores being within normal limits, sometimes we still want the service to continue to try to promote further reorganization. But I digress a little bit. So outside of school, we're going to want related services to add to what we're getting in school. And then we want any resources that are relevant to the findings. So if we find someone is having some distress or some behavioral concerns, we're going to want some therapy, right? And that therapy could involve, could involve working with the individual. When we're talking about kids, almost always I'm going to want some work to be done with the family or the parents, the caregivers, to help that therapy along. So in other words, if a child's having behavioral concerns, I don't know, disruptive behavior, impulsive behaviors, we're going to want to work with the family the parents on understanding the sources of those and coming up with different ways to manage those more effectively. Situations where there is, are stressors that contribute to the problems, we're going to want supports, case management supports. If there's a caregiver has an illness, we're going to want that caregiver to have supports. Sometimes case management services can help us coordinate services across the child's life. Like, let's get the program going at school, and now let's get these programs outside of school. Someone with an autism spectrum problem, we're going to want ABA therapy, and the case managers can help us to acquire that. Sometimes a mentor for a child who is struggling socially, so different aspects. Whoops, where did I go? We're going to want medical, their physicians involved, their neurologists involved. Is there, they're having trouble sustaining attention, or there's a stress response concern and anxiety. So we'll also want to get the doctors involved for medical management of those concerns. Sometimes we want the, child who is having distress or some problems in living, we're going to want them to have more, extracurricular and pleasurable leisure and social activities. In some cases, we'll want social skills groups to assist with social skills. Sometimes we'll want tutoring to help bolster the language. So overall, what we're doing, so now we would utilize all the resources in the school setting and in the community to develop a full program of intervention, and then run that program of intervention with some follow-up. The follow-up serving to give us further information about sources and diagnostic clarity, and also telling us what we need to do now, right? So in the best of worlds, the family will take the report and get the program set up, run the program for some time, and then we'll see the child again in a year or two to not only better understand what's going on, to see how our program is doing in terms of addressing the concerns that we wanted to address. And then also, are there additional things we need to be doing now, right? I hope that makes sense. That's it. Does anybody have any questions?
I had a few questions. My name's Annette, and we have a 7-year-old granddaughter with Sturge-Weber.
Okay.
Mom wanted me to ask, they had to leave for baseball, unfortunately. Do they do IQ testing during the neuropsych?
They absolutely would. So that when I was talking about the cognition part or the intellect part, it's a very important aspect of any reasonable neuropsych. You're going to want to fully understand intellect. Yes.
Okay. I'm sorry, there was a couple. So Brielle's been jumpy when there's little bits of noise. Should we bring this up to them when she's going in for testing?
I absolutely would. So that I think that would be useful information to know. And again, when whoever's doing an assessment does the intake or goes over the history, they're going to learn about that, right? And not only can that help us prepare to make sure we're getting really good data when we're working with the child, right? But there may be aspects of that concern or symptom or whatever we want to call it that will want to understand better to make sure, we fully understand that symptom and ways to manage that, right?
Right. I don't want to take up too much time, but when it comes to, she's had brain surgery, how often should there be testing done? We know there should be one done before and after. But we have questions from other families who are going in for testing, and I'm like, well, I'm not 100% sure. Let me ask when we saw the doctor.
How old is she?
She's 7. She had her brain surgery at 3. She's due to have one at 8. So
A surgery?
no, and another neuropsych.
Oh, when did she have the surgery?
She had the surgery in 2019.
How old was she then?
I mean, 2017, right, Heather?
So she was
2018, she was 3.
okay.
3 and 1 month.
Yeah,
Yes.
what in her last assessment was when she was 3 years old?
I believe it was just after a year after. Mommy's in and
Okay.
out, running to
So
go to
4,
baseball.
okay. How's she doing in school?
She's doing wonderful. Her math skills are incredible. She's in 1st grade doing fractions.
Do teachers have any concerns about any aspect of her learning?
They have not, but to be honest, her primary teacher has been out due to medical issues, and she's had numerous tutors. So we can't even go by what she's learned since January, except what we've taught her here at home.
Do teachers have any concerns about any aspect of behavior in school?
No.
Okay, good. Good.
Yeah,
That's
she's
great.
very pleasant, they said. So they're not concerned about that. Our concern is whether or not she's getting the proper education due to the lack of a teacher full-time.
How's she doing with her friends?
She has a lot of friends, but she tends to now, she's starting to pull away from a few because of their behavior issues. So she's getting scared in school. So that was another thing that we brought up at a recent IEP meeting.
Do you and Mom have any concerns about any aspect of her functioning these days?
Mostly about the easily scared and jumping and her safety in school, because she's been hurt a lot. I
would say, it wouldn't, look, I think I would probably say, I don't have a real, I would say where do you live?
We live in Rhode Island. We go up to Boston Children's, which, like I said, she's due to have one at 8. So
I would get that. I'll just be honest. If it was my daughter, I'm probably getting her assessed before the beginning of this next school year.
Yes.
Just because I want to know, I just want to know everything is okay. I want to know if there's anything we would need to be doing to help her. And again, given the history, so early surgery sounds like it was very successful, and that's great. But I would want to, even if, like I was saying, in almost all the work I do with children with a history of, with Sturge-Weber syndrome, maybe a history of surgery, I want to, even if it looks good, I'm going to want some services to just try and, I'm assuming there's really great reorganization of functioning going on, but now I'm greedy. I want more, so let's just keep going down that road. Does that help?
That does. I appreciate you very, very much.
Thank you.
Awesome. Karen, it looks like you have a question.
Oh, yeah. Well, actually, Dr. Beher, I have many questions. I will try to just do the same as Annette did, like try to resume it.
Okay.
My little cousin, he has 6 years old, and he lives in Colombia, in South America. We have been just having issues because physically he's pretty well. He's a very strong boy, an active boy, but now lately behaviorally has been the issue. So he's kind of aggressive. He has anxiety and oppositional defiant disorder. And also he's now beginning to be rejected because of his mates, because he attends just a regular school. He lives in a very small town, so there is not a specialized attention for him. Her mother tries to do the best, and we have a team of doctors that attends him, but most of the time the thing has been like after the issues happens, the doctor says like, oh, it's because of the syndrome. But we want to try to be like one step ahead, because for example, he has good memory, he likes to talk a lot, but he has some problems like writing and like doing like long lasting tasks. So is there like a way to improve his behavior, for example, without giving him a medicine, like a prescription of medicine?
So it's a good question. So here's what I would say. How old is he again?
6.
6. Okay. So the list of the problems you just mentioned, the first thing I would want to do is fully understand them, right? Like, so the question about, is there a way to do this without medicine? It's a good one. Here's what I would want to know. I want to know what the sources of each of those problems are, because I don't because from the description we have right now, we know he's having, some behavioral concerns, some impulse control concerns, maybe some anxiety, starting to affect his social life, some writing, maybe some contributing to some concerns at school. I don't want to guess. I never guess about anything. I want to know what the sources are. I think a really good place to start here would be with a full evaluation to really understand what are the sources. Again, someone says they're having behavioral problems or problems with their friends, and I want to know, I want to go through that whole battery. I want to know, is there any cognitive problem? Is there a language problem? Is there a learning concern? Right? I want to
Okay,
know.
so
I want to know
there's-
those things
I'm
before.
sorry.
That's okay. Before I start to say what we can do, I want to know what are the problems, and then what are the problems? What are the sources of those problems? And then we can address them. Does that make sense? Now, where do you live?
He lives in Colombia. We've been talking lately with Dia to try to see if we can improve, because in Colombia also, he is the only patient that we know actually in Colombia. There is no like an organization in Colombia. So her mother has been like challenged with all these things, and lately the behavioral thing that has been like even more challenging. And we have been like trying to do like the most of the things. But I live in Mississippi right now. And she is here because she doesn't know how to speak English, but I'm just the channel to make the questions.
Will she be coming to Mississippi at any point?
Well, we're trying to see if there is a chance that she and the kid and my cousin could like come to United States, especially like for this kind of evaluation. We're trying to figure it out how to do it.
No,
But,
let's do this. I got an
chance
idea. I got an idea.
Okay.
Send an email.
Okay.
Can you send an email to myself and
Yes, I was asking.
Dr. Chaba Yuhas? Okay. And let's see what we can find. We'll try to find folks both in Colombia and the nearest folks in Colombia and or in Mississippi, whatever you can. Send an email and we'll work with you.
Okay, could you
Karen?
please give me
Karen,
your like
send
your
me the email. Karen, I'll send an email to all of you together.
Okay,
and I'll get you
perfect.
some-
Okay,
yeah.
thank you so
Perfect.
much.
Yes.
Perfect. And then
Thank
we
you so
see
much, Dr.
what we
Behen.
can figure out, okay?
Absolutely.
All right, thank you
Chaba's
so much.
great.
I can send you
Chaba's
like
very
the.
effective.
Oh,
Yeah.
okay. We have
Yeah.
like one evaluation, so I can send it to you.
Oh, that's
That's
good.
good.
And then, okay, that's good. That'll help. And then we'll see if we can find some resources for you in either setting, okay?
Thank you so much.
All right.
All right, thank you.
Now, Dr. Behen, someone asked what is the youngest you can do a neuropsych testing?
So I would say, I'm going to change the word neuropsych testing to evaluation, okay?
Yeah.
So I think if if there's concern around a child's development, right?
Mhm.
And let's say, I want to know, I think it's useful to talk about regardless of the age. Like so for a child under 2, we're not going to get a full neurocognitive battery, but you know what we can get? We can get measure of where they're at across developmental domains. We can get some understanding of there's, social relating. If there's anything looking like any concerns around social relating, we get some ideas there, with even a child, 16, 18 months, right? We can get some idea if there's any developmental delays, we can get some idea of what their behavior looks like relative to other children their age, right? So that question, the asker of that question, is there an age of a child that we're thinking about?
Wendy?
The children under 2. So my kid's is currently 1. And I was curious what you said about doing testing even when they seem, when there's not any problems yet. To speak more about, you said something about relocation in the brain.
How old is the child? How many months?
About to be 1-year-old.
And is there medical concern? Does the child have Sturge-Weber?
Yes.
Okay, and who are you working with, doctor, neurology wise?
Just a pediatric neurologist.
Does the neurologist have any concerns?
No, not yet. That's why I was wondering about, like, well, I was curious what you said about when there's no concerns, but potentially could be useful to do more direct.
Yeah, you know what I would do? So what's the neural involvement? Do we know? What's the MRI and everything showing?
There's extensive leptomeningeal involvement in the temporal lobe and along the brainstem.
And what's your child's name?
Her name is Sophia.
Is Sophia getting any service now?
No.
Okay. I mean, I would, talk to your neurologist, and I would mention, hey, do you think it would be useful to get some, speech, OT, PT, given the presence of Sturge-Weber? Any medical concerns, seizures or anything?
Not yet, no.
Okay, good. Look, I would, definitely. Where do you live?
In right by San Francisco.
Okay. I would talk to the neurologist, say, given the presence of Sturge-Weber, we were thinking, maybe we get initiate some early intervention. The doctor might say, look, it doesn't look like you need that to me. Again, if Sophia is my daughter, I might, I might say, you know what, though, I'm going to get some early intervention anyways. It won't hurt, and given, some neural involvement, I think it's a reasonable to maybe, again, I would talk to your doctor and see what he or she thinks, but yeah, I'd be in favor if you called me, you lived in Detroit and called me, I would say, yeah, let's get you, let's get some early intervention going. Just help, only help.
Yes, thank you.
One last hand, and then we have to go to the next speaker, okay? It's the one that just says iPhone.
Hi, sorry, I don't know why I only say iPhone now. It was a little bit of a similar question, so perhaps you've already answered it. But it was that my son has Sturge-Weber, right side of his brain, but currently is age appropriate for, he advanced out of speech. He's still in OT and PT for like low muscle tone, that sort of thing. So I just been finding that, especially with a lot of the public school stuff, it's like very reactive. And they're like, well, as long as he can walk to school, he's fine. As long as he can sit in school, he's fine. As long as I don't see these things, it's fine. And so it has to like reach some sort of threshold for it to be an issue. And so I guess I was wondering you were speaking before about like making reconnections and why you should continue the service, even if they're technically age appropriate. And I was just wondering if you had even any more language so that I can go back and be like,
yeah,
okay, no, well, like technically, but we should keep going.
It's a great question because the question, so it's like, okay, my child, it's your son?
Yeah, my son's 3, just turned 3.
And what's his name?
Kieran.
All right, so Kieran, Kieran's doing, great in the world, and schools usually operate under the idea of least restrictive programming, right? And
Yeah.
and it, and that's great and everything, but here's what I always say when it's with cases like Sturge-Weber syndrome, I will say to them, we have to explain it. We can't assume that they understand why we would want service if the child is doing fine, but it really is because we know there's neural insult or neural atypicality. And because of that, we want to promote as much, healthy reorganization of function as we can. And one thing that we know is that providing intervention services helps with that process. And so I usually write a letter and just explain, yeah, I know he is doing well and we're really happy, but given this neurological, atypicality, we want to continue to provide early intervention to absolutely promote the maximum level of neural reorganization that we can. And they'll usually, what city do you live?
Fairfax County, Virginia.
Okay, I rarely,
They're good.
yeah, rarely do schools say no to that. Once they understand, there's a neural situation that we want to get the very best outcome from, and the research has always informed us that, early intervention is a useful way to promote it, as much reorganization and function. And that's what we want, and so I would just kind of help them understand that if a letter would ever help, you can, again, email Chava and myself, and we would be glad to write a letter.
Cool. Neural reorganization sounds very fancy. So hopefully that will be
No, we're just
helpful.
saying, look, we know there's this thing, that's not typical. And we want to make sure that we, optimize this nervous system to the maximum extent possible, and then, sometimes giving them information to read about Sturge-Weber can help too, and usually that gets everybody on board.
Cool. Thank you.
Great questions, you guys. Good job, by the way, all of you.
Yay. Dr. Behen, thank you so much for all your help today. And thank you for this wonderful conversation. I wish I could take more questions, but we have some assistive technology conversation coming up
Okay.
next. But I will tell you that if anyone on the line is interested in the study, please email me because we can get it over to Shaba and to Dr. Behen, because it's a fantastic study. We'll be heading your way in October, I believe.
All right. And I just found out we're going to be seeing you guys in, I think, September in Boston.
Yes.
Yeah,
Oh,
I
you're
can't
coming
wait.
too?
Yeah, we're coming.
Yay.
Yeah.
Good,
All
good,
right.
good. All right,
All right.
we'll see you then.
If
Thank you.
anyone has questions, they can email. Okay.
Yep.
Thank you. Have a good day.
Thanks, Dr. Behen.
Okay, bye.
Bye-bye. Okay, guys, that was a great conversation. And we're going to change it up just a little bit. We have a wonderful gal with us today. Kristen Russell is her name. We were lucky enough here, my daughter, to work with her. She's an occupational therapist and an RESNA certified assistive technology professional. And she's going to tell us, I know we're running it a bit late right now, but this is going to be an exciting talk about some ideas that you can do with assistive technology to overcome some of those things you might learn about in that neuropsych exam or that we just learned about. Kristen, I'll let you take it away then when you get a second.
Sure. I'm just rearranging things because then I can share my screen a little bit better.
Excellent.
Is it okay if I go ahead and do that, Julia?
Yes, please.
Okay.
And in the
Awesome.
meantime, if anybody had any questions from Dr. Behen, please don't hesitate to give me a call. He's always very supportive and he'll go ahead and get us answers as well.
Awesome. Well, I think I'm ready to go. Thank you guys for giving me the opportunity to talk about assistive technology. It's one of my favorite things to do. So I'm super happy to spend a little bit of my Saturday with all of you. So Thanks for the quick intro, Julia. I've had the great experience of working with you and your family. And today I'm going to talk about some assistive technology tools and even more importantly, how to access some services. So just a quick little background about me. I'm an occupational therapist is my background and training. And I've been working just doing assistive technology for I don't know, probably 17 or 18 years now. So in my role, I work for a nonprofit in New Jersey. We provide services all throughout the state. So we're working in school districts. We're working with vocational rehab. So adults, young adults, even going to college with disabilities and helping them figure out what assistive technology they need for college and for the workplace. So we kind of run all different age groups and stages of life. So, and I'll just say, as we kind of get started here, if you guys have questions, you can feel free to just put it in the chat and unmute yourself. And sometimes it's easier just to answer some questions like right in the heat of the moment. So Julia, if you see something come through, feel free to point it out. Okay, so real quick, I'm not sure where all of you are with your experience with assistive technology. So I'm going to assume that for some of you, this is a newer concept. So I'm just going to kind of talk about some of the background. So I'm going to read to you here the official definition of assistive technology. So it's any item, piece of equipment, or product system, whether acquired commercially, off the shelf, modified, or customized, that is used to increase, maintain, and improve the functional capabilities of children with disabilities. And I would change the children to really anyone. So I think really the key takeaway here is it's anything that's used to help improve somebody's abilities. So kind of if I were to put that in my own words, assistive technology is really any tool that's going to help a person with a disability perform a task more efficiently or independently. So assistive technology is very, very broad, okay? And it's all individualized to the particular person who's using it. So just to kind of give you some ideas of the vastness of the field of assistive technology, there's tools that can help people communicate. So anybody who is not able to communicate verbally, there is lots and lots and lots of assistive technology that would fall under the area of augmentative and alternative communication. So using a device like a tablet or some type of device to communicate. All sorts of tools to help somebody use a computer. And probably what I'm going to talk about most today are tools to help people who have difficulty with reading and writing be able to perform those tasks more independently. There's lots and lots of tools for more executive functioning type tasks, which I know kind of came up a little bit in the last presentation. So also sorts of technology for reminders and schedule and to-do lists and staying on task and focusing and all of those things that lots of us have some difficulty with. And then there are, of course, assistive technology tools for activities of daily living, like dressing, bathing, eating, and recreational activities. You know, there's all sorts of adapted equipment for video games and sports and that kind of thing. The one I left on here, of course, is mobility. So wheelchairs and any other adaptive equipment that helps somebody with mobility. But you can even think of things like hearing aids, glasses. Those are even assistive technology because they're helping somebody do something that without it would be very difficult. Okay, so assistive technology is really made up of the tools, which is everybody's favorite part, but also the services, okay? So the tools we're going to talk about in a minute here are really classified low-tech, mid-tech, high-tech. I'm sure some of you have seen that wording before. And also the services. Okay, so this is my little soapbox. Obviously, I think the services are very important. That's my whole job, is to provide assistive technology evaluations and trainings and professional development. I'm sure if I were to ask each of you individually about assistive technology experiences that you've had with your child or people that you know, a lot of times expensive equipment is purchased and not used or not used fully, or maybe it's used and then it stopped being used because something happened and we didn't maybe nobody was in charge of figuring out the problem and fixing it, or, you know, the device just got old and was now really not the current technology, so not appropriate because of that. So that's where the assistive technology services come in. So while the tools are the much more interesting thing, and there's so many awesome, cool things out there, if anything, if you take away anything from today, any tools that you think might be relevant for your child now or later on in their education, just also really keep in mind that the services are really important. It's important that there's somebody that is there to facilitate things and make sure the student knows what they need to know, but also that the parents know what they need to know about the assistive technology tool, and the teachers and anybody else at school working with a student. Okay, so just to kind of give you an idea of what we're talking about when we talk about low tech, mid tech, and high tech, I just put some pictures here. So low tech would be really simple things that you guys all know of. Highlighting things on paper to draw a student's attention, trying different pencil grips, Post-it notes, a paper to-do list. Those are all considered assistive technology tools. They're just low tech, okay? And because they're low tech does not mean that they're not as good tools. Sometimes the best tool is a low tech tool because we don't have as many issues with them related to technology. Lots and lots of tools I would put in the mid-tech category. So that keyboard that you guys see up top, that's a keyboard that would be helpful for somebody with some type of a physical disability that makes typing on a regular sized keyboard difficult. So these keys are a little bit bigger sized. And also there is what's called a key guard on top of that keyboard. It's a little plastic sheet of plexiglass. It's kind of hard to see in a picture, but this would help guide a student's finger right into the keys, and they can kind of rest their hands on that keyboard and move it around without pressing buttons that they don't mean to. Other low-tech tools, I'll show this one. Oops, didn't mean to click on that. This right here is a reading pen called a C-Pen reader. This is a really cool piece of technology where it allows you to scan a row of text, similar to how you would trace over text with a highlighter. And as soon as you trace over it, it'll read those words right out loud to you. So this is great for anybody with some difficulty with reading, although there are a lot of other tools out there that I'll show you a few of today. I would also put our smartphones and tablets into this category as mid-tech or maybe high-tech, somewhere kind of in there. Nowadays, people, even kids, often have their own smartphone, and we all tend to keep our smartphones with us throughout the day. They're never too far away. So they are incredible assistive technology tools. So of course, there's tons and tons of apps, but just using reminders and alerts, any type of notification can be really huge for someone who is struggling with memory or time management. We can really use the phone in a lot of ways for free or low cost that can really make a huge difference. Moving into kind of high tech, I just put one example here, and this also is probably kind of in between mid tech and high tech, but using smartwatches. So this is an example of an Apple Watch here. Again, a lot of people have them more and more all the time are obtaining a smartwatch. And while I think a lot of people would think that's kind of gadgety or just like a little extra or some cool fancy technology, it can be a huge assistive technology tool. Again, for those alerts and those reminders and the quick access to alarms. So, you know, these are tools that kids are often willing to use, and they're getting a lot of benefit from them socially, or, you know, they just enjoy using them. But we can really maximize these tools as assistive technology tools as well. Okay, so now we're going to talk a little bit about IEPs. So for your students with IEPs at school, assistive technology is a part of that. And I want to make sure that you guys understand how assistive technology kind of plays into the IEP process. So all IEP teams have to consider the student's need for assistive technology. So if you look at your child's IEP, there is a question on there about assistive technology. So this active consideration, which I'll talk a little bit more about, should be part of every IEP meeting, okay? So what's difficult about thinking through whether assistive technology is appropriate for a student is there's so many tools, okay? You know, it's unrealistic to expect everybody working with a student is just going to know all of the options that are out there. Even me, as someone who works in the field, I don't know everything. There's just so much and so many new things. So, but we still have to do our best to learn as many things that are out there and different types of tools and find the information that we need to help our students. So first of all, it has to be, assistive technology has to be considered. If the IEP team decides that assistive technology is necessary for that student to access their free and appropriate education, it needs to be documented in the IEP. So listing what assistive technology is needed, how it's going to be used, what are the supports that are going to be required. Okay, so it would be the district's responsibility to obtain that assistive technology if it's determined by the team that it's necessary for that student to be accessing, you know, their education to the fullest. And assistive technology should go home with the child if it's needed for homework or communication. So going back into that consideration process here, consideration doesn't, so I'm talking about the consideration of assistive technology, which is part of the IEP process. This is not an evaluation. I'm not saying that every student needs an assistive technology evaluation. That's not necessary. What consideration is just talking through, brainstorming, are there assistive technology tools that might help this student? Okay, so if you haven't had your IEP meeting yet this year, you know, this would be a good time to bring it up and to say, you know, I'm seeing that my child is not making a lot of progress in whatever area. Maybe it's reading or writing, or I'm seeing that, I'm hearing that people have to read things out loud to my child because they're struggling to read it independently. That should get us thinking, oh, maybe there's another tool that we can use so that the student can do it independently. So it's really just brainstorming, asking some questions, thinking about what is out there, what could we potentially try? And if there's not, if it's needed, an assistive technology evaluation may come out of this, okay? If the team is not really sure what's available out there, or we just determine that it's a really complex situation and we need somebody that has more specific training and skills in that area, that's a possible outcome. But it might be another outcome that there are things available in the district and ideas that look helpful for the student, and then we can just start trying them out and seeing if they're going to work. Okay, so one way to start this conversation, I kind of already said this, but I'll just say it again because I think it's a good way to kind of break the ice. We've been working with Anna, or whatever your student is, for the past 2 years on whatever the task is, reading, writing, whatever it may be. She's making minimal progress despite all of the interventions that the school's doing. Could assistive technology support Anna in increasing her independence and success in this area? Okay, so one other thing I'll just touch on briefly. There is a framework in assistive technology that's really commonly used. It's called the SET framework, and maybe possibly some of your school districts already use this, but it's a way to think through all of the factors that lead to identifying what the assistive technology would be for that student. So thinking through that in a very systematic way. So SET stands for student. So we're thinking about the student and their abilities or strengths, the areas that are difficult, anything about the student. We're thinking about the environment, you know, what type of classroom it is, what tools are available, how loud it is, all of that kind of stuff. And then we're really honing in on what are the specific tasks. Okay, so like in my example before, I talked about writing specifically as an area, but I could even go even deeper and say, spelling is a huge roadblock for my child to express what they know in writing, or handwriting is a major barrier to my student expressing what they know in writing. Okay, so really dialing in on what the tasks are. Sometimes we'll get referrals for students where it's very general. You know, we just want to know what's out there, you know, that could help my child. That we need more details. We need to really narrow it down to the very specific detailed tasks. And then we can match, you know, once we're taking in all of this information on the student, environment, and task, then we can jump to the tools. Okay. And while this seems really obvious, a lot of times we just jump to the tools. We want to get that iPad app that we heard about, you know, on a Facebook group, or, you know, we want to, you know, a special Chrome extension or something, but we really want to think through whether that is exactly the right path for us. Okay. And anytime we're thinking about an assistive technology tool, we always want to trial things out, unless it's absolutely not possible, but we usually can find a way of a free version of the app, or a free demo of software, or maybe it's, you know, something that can be borrowed, but we always want to try something out. We don't want to waste our time using a tool that's not actually helpful. Okay. Even if you thought initially you were pretty sure it would be helpful, sometimes things just don't pan out working for whatever reason. Okay. So mentioning how to trial tools. So like I mentioned, there's a lot of free demos out there, but for like software or apps or Chrome extensions, and a lot of things are free, but each state in the country has an assistive technology lending center. And I put this link in here where you can go and you can look up your state. Okay. In New Jersey, the agency that I work for, Advancing Opportunities, houses that Assistive Technology Lending Center. So if you happen to be in New Jersey, you could reach out to me. You can click on this link to find out more information. But basically, there is federal funding. So each state can have items in their state to loan out to people. It's a free service in New Jersey, and I think in most states, to really try before you buy. Okay, so things like there's lots of communication stuff, keyboards, mice. We loan out iPads with specific apps on them. Like if the app costs money, for example, you can borrow an iPad with the app on it. So lots and lots of different equipment. Okay, so most of our students have technology in their hands already. I would assume that most of your children or your students have Chromebooks probably in their school districts, at least in New Jersey. That's mostly what we're using, but certainly iPads, especially for younger students. People also have Android tablets, Windows computers, Mac computers. All of these tools, really any technology device, I would say, for the most part anyway, are going to have lots and lots of built-in tools. So these are part of the operating system of the Chromebook or the Windows computer or the iPad. Okay. In particular, iPads have tons and tons and tons of built-in accessibility tools, many of which years ago we would pay a lot of money for, but now they're just part of our phones or our tablets. So I would always encourage you to kind of explore those options. If you're thinking maybe there's some things that would help, whatever is going on in your situation. If you have a Chromebook, I would just kind of do a Google search for Chromebook accessibility tools and watch a couple of YouTube videos and see what jumps out. So on this slide, I'm just showing, some of the Chromebook accessibility tools just to kind of give you an idea. So there's all devices are going to have a lot of different visual components. So if we need a magnifier, if we need the things to be magnified, we can do that within any device. We can change the contrast. So it's a black background, for example, with white text. We can change lots about the keyboard, especially for students who are using one hand or don't have great motor coordination and having some errors. There's all sorts of settings to change the mouse. You guys might see, I think this will come through Zoom here. My mouse cursor is very big. You can do that on Chromebooks as well. You can change the color. You can adjust the mouse speed. So always be thinking I might not need anything extra. I just might need to go in and tweak a setting. Same with iPads. Okay, so this slide would apply to iPads and iPhones. There's tons. This is just a snippet here. Tons of different different tools available in their accessibility settings. So you just go into settings and accessibility and just kind of look around. Again, tons of vision things to make things bigger, lots of different things that will read aloud, and lots of different settings for people who have any type of bit more physical disability to use the device. So I wanted to show you a couple of the things that I would most commonly use or recommend. So I'm going to talk a little bit about reading and writing. And Julia, cut me off if I can't remember what time I started, but cut me off if I'm if I'm talking too long. But I don't have too many slides here.
No problem.
So one of the most common tools that we're recommending for people who have difficulty with reading and writing are some type of text reader tool. So what I mean by a text reader tool, and I'm going to show you one here in a second, is that there's text on the screen and the student's going to see it. And as you can see in this example, it's actually being highlighted, which is great to take it up a notch, but they're also going to hear it. Okay, so this could be helpful for students who have trouble decoding or sounding out the words. Okay, so let's say your child is struggling to decode these words or trying to read them, but if you read to them, they're able to comprehend it much better. That's an indication that a text reader tool may be helpful. Okay, so when we're recommending a text reader tool, we're not saying stop working on reading, right? We're still working on reading. You know, students are still getting all of the reading instruction in school, but we can also add in a text reader tool so that student can continue participating in reading and doing so independently and having access to books that maybe are on their comprehension level, but not at their independent reading level. Okay, so we don't want students who struggle with writing or reading to get so discouraged because reading is so difficult that they don't want to read and they're feeling very negative about it. Okay, so on this next slide, and I'm happy to share this presentation, Julia, I can send you a link so people can click on these links. These are a couple great Chrome extensions. Okay, so these will work on Chromebooks, but they'll also work on Windows or Mac computers with the Chrome web browser, which is what a lot of people use. So these are three of my go-to tools. They're all really wonderful. So what I'm going to do is pull up, I'm just pulling up an article on here. So I will just show you here. I have a couple of different Chrome extensions. So these little things that I'm pointing my mouse at, these are just little programs that I've installed on my computer. Some of them are free and some of them are paid, and they act as like little software programs. So I'm going to turn on one, actually it's already on. It's this one here that looks like a bullseye. This is a text reader program called Snap and Read. Okay. All the student has to do is, if they want to read this text, is click on this little speaker tool and click where they want it to read, and it'll automatically read aloud.
A little more than 1,800 giant pandas exist in the wild.
Yes?
Kristen, we can't see what you're doing. We could hear it, but we couldn't see what you're doing, I don't think.
Oh, really? Oh, shoot. Okay. Let me stop sharing. You know what I probably didn't share. The right way. Can you see that now?
We can, yes.
Oh, okay. I think I just did the wrong type of sharing. Okay, so I'll show you again. This program, this little black bar along the right side of the screen is the Chrome extension. So this is my toolbar for the program called Snap and Read. So again, I just click on it, the speaker tool, and I click where I want it to read.
A little more than 1,800 giant pandas exist in the wild. But
okay, so I don't know if you could hear that voice. That's just one electronic voice. It's not for everyone. That's a very deep voice, but there are, of course, all different voice options. You can adjust the speed at which they speak. So this would work on the majority of different websites out there. So lots and lots of things that students would have to read would be able to be read aloud by this, or the other Chrome extension tools that I put on the slide. Read and Write for Google Chrome is a great one. And then another one called Natural Reader, which I don't think I have installed here. So another thing I want you guys to know about is that there are different services out there. I'll name one. This is called Bookshare. I'm just on their website here. Bookshare is a free service. Again, it gets federal funding, as long as for students, I should say, like K to 12 and post-secondary. Students can get a free membership. It's super easy to join. And basically what it is a huge online library of books in an accessible format. So you can, look up, they have hundreds of thousands of books available. If you find the book that you need, it can be opened in the Chrome web browser. I have an example book up here. I've changed and made the text a little bit bigger, but you can customize that. You can also open books on an iPad using particular app. So really you can access these Bookshare books on most devices, I should say. And what it allows you to do is then to listen to them. So if I click this,
79.
it'll start reading to me. Okay. So there are accessible books. So if your student's class is reading whatever textbook or a novel, and you want your student to be able to listen to it while also following along with the words, Bookshare is a really great resource that I would point you to, and it's no harm done. It's a free tool. So let's use it. The other great option that maybe some of your school districts are using is called Learning Ally. This one's not free. It's not ridiculously overpriced. A lot of schools already have this. So it's something you could already ask. This is very similar to Bookshare. However, these Learning Ally books have human readers. So they have volunteers that have recorded the books. So it's a little bit natural sounding voice. So I love Learning Ally, especially for elementary age students, because I think it aids in their comprehension a little bit better because it's a more natural voice. So one thing I neglected to say, for either of these, for Bookshare or Learning Ally, the student does have to meet their eligibility requirements. So that is the student has a visual impairment or blindness. The student has a physical disability, which makes it difficult for them to manipulate a book and turn pages, or the student has a learning disability in the area of reading. Okay. And really all it is like a very short document where somebody who is a competent authority, which a school case manager, a psychologist, a doctor, it lists on the registration form. They really are just checking a box. You're not submitting testing or that kind of thing. Okay. So Bookshare and Learning Ally, check them out. All right. So now we're going to talk a little bit about a couple of tools for writing, and then we'll see if there's any questions. So, one of the most commonly used, and I'm sure lots of you on this call right now use it yourself even, a great support for writing is dictation. So being able to talk into the computer. So this is great for students where handwriting is a barrier, where spelling is a barrier, or students who just do better just getting the thought secure in their mind and getting it on paper by saying it. So in case you aren't aware, this is a built-in tool in a lot of devices as well for free. So since many of our students are using Google Docs, I just wanted to show you this one. So I'm just in a blank Google Doc. I go to Tools and then Voice Typing. So I always tell students, look for the little microphone there. And then all they have to do, if it's your first time, you would just have to allow them access to the microphone. And then they click. Today, I am giving a presentation on assistive technology, period. Hopefully everyone is learning at least one new thing, period. Okay, so I've done a lot of dictation. I'm pretty good at speaking clearly into the microphone. That's a learning curve for our students. But even students who do have some articulation errors can do pretty well with dictation. It can at least help a good bit get them onto paper. Okay, but like I said, there's dictation available on most built into most devices in some capacity. All right, so I'm going to talk specifically about a tool for spelling. I'm going to show you guys another Chrome extension. I'll show Co-Writer. So I'm just going to turn on this little Chrome extension here. And this is a word prediction program. So if I'm trying to write the sentence, tomorrow I'm going to the beach. If I'm a student who struggles with spelling, a lot of times what I'm going to do is find more simple words to spell because I know tomorrow and beach might be hard. So I might simplify, I might write less. So what this tool does is it tries to predict the word you're saying. So just like it, you know, most of your cell phones probably have that feature turned on. This is that, but just a little bit more robust. And it will do a little bit better at guessing what a student is trying to type, even if the spelling is more phonetic. Okay. So I wrote TO, I can see the words in my list. I can hover my mouse over them to hear it if I'm not quite sure I'm reading that one. And then I can select it by clicking on it or hitting the number 4. Okay. And then if I know how to spell the word I, so I'm just going to ignore that box. And like, let's say I kind of know going, but I see it there. So I'm just going to hit the one to the beach. Okay. So if I'm not sure, I'm going to listen.
Tomorrow I am going to the beach.
And you probably couldn't hear that, but when I put in my punctuation, it read it right back to me. So that's called text to speech. That's a huge, huge help for a lot of students who are struggling with reading. So their proofreading is going to be impacted by that. Okay, so that's a quick example of word prediction tools, which are super, super helpful. I put a couple of options in there. Okay. So the last thing I wanted to just show you guys is whenever a student, just going to turn off my word prediction here. Whenever a student is using dictation, if they're dictating into a document, if they're using word prediction, or even if they're not using any of those tools, I think it is always a good idea for students to listen back to their writing to help them in proofreading. Okay, so that's called text to speech. So this goes back to the reading tools I talked about a couple of minutes ago. Any of those reading tools will read the text aloud. So here I'm just, here I'll show you the one other one that I use a lot. This is called Read and Write for Google Chrome. This little toolbar that popped open. If I put my cursor at the beginning of where I want it to read and hit my play button.
Today I'm giving a presentation on assistive technology. Hopefully everyone is learning at least one new thing. Tomorrow I am going to the beach.
Okay, so this is something I personally use. I proofread all of my reports using a text-to-speech tool that's built into Microsoft Word called Read Aloud. I'm just stronger auditorily. So I think it's great if, you know, for one, we can tap into the visual, but also the auditory skills that a student might have to really cover kind of all the bases and help them to be more independent rather than passing the paper to mom or to the teacher to proofread. They can at least start doing this independently. Okay, so that was the last thing. I could go on and on and on, you guys. But I know you you have other things you need to do today. So if there's any questions, I'm happy. If there's time, I can answer them now. You are also welcome to reach out to me via email or phone, you know, whenever something comes up, and I'll point you in a direction if I can.
Thank you, Kristen. I'm going to also, if you don't mind, just introduce a couple other folks that joined us in the meantime that we're going to be here for questions too. If you don't mind, do you mind hanging out for 10 or 15 minutes?
No, yeah, that's fine.
With us today, we also have joined with us, Dr. Anna Pinto is with us. She's a neurologist out of Boston Children's. We have Dr. Fauch, who we talked about earlier, who is a research scientist in ophthalmology from the Mayo Clinic. And we also have Dr. Mo Levy, who is a dermatologist at Dell's Children's in Texas. So this is your opportunity, everybody. We have Kristen Russell, as you just heard her talk. We can talk about anything now. We can talk about assistive technology. If Dr. Fouch can't answer the questions in ophthalmology, don't panic. We will get those questions answered from other ophthalmologists, but he does do the science of it. So it looks like we do have a question already in the box, and it says, is vibration plate useful for Hemi kids? I don't know who that's put to or what, how that would
I'm not sure what that is, if that's geared toward me.
I don't know. Tila, do you want to explain that a little bit better, please?
I just saw in this Sturge-Weber page today something about vibration plate. Maybe it's kind of exercise, muscle, something, no, loosening tool.
Huh. And that's okay. What I'll do is I will get more clarification on that one, because that one I don't know. Unless anybody else has an idea. Tila, we'll get
It's
clarification on
okay.
that.
Just I've let me tell what I've read from that page. Some parents, they ask about vibration plate. Is that really useful? And some parents, they answer like they use for the part that is quite like for hemi kids. If one part of the body is not that much flexible, so it helps them with that.
I gotcha.
Okay, I'll drop a picture over here.
Okay. In the meantime, what I might be able to do is get it to a rehab specialist too, Tila, to see if maybe they work with it from that perspective. Because it sounds like that's where that would be headed.
Okay, thank you.
No worries. Anybody have any questions? Well, don't fret.
Do you want the question specific to OT or to some of the new people that you?
It can be
mentioned?
anything. Any one of those questions, any one of the specialists that are here with us today.
Okay. I had submitted a question. This is a dermatology question. And that it relates to the changes as, so my son is now entering puberty. And of course the skin starts to change. Not so much specific to the port wine stain, but the typical changes that happen to all prepubescent skin, and how to care for it on the port wine stain side. If, I don't know if typical products for, acne are too harsh. He does seem to be getting more on that side. And so we just have questions about that, and we don't have access to our dermatologist until November.
That's a problem with many of us, I will tell you. I'm sure Dr. Pinto has no problem getting her patients to see my colleagues up there at all. But in any case, that's actually a very good question. And I'll tell you, first thing is with all types of vascular birthmarks, in this instance, capillary malformations, those areas can just naturally be more subject to, I'll say broadly stated, irritation. It's not at all uncommon to have increased dryness, for instance, or inflammation, creating more redness or discomfort. That being said, I do not specifically, because of those differences, engage in any different therapy, for instance, for acne, as you bring up. I mean, starting with a low concentration, for instance, of a benzoyl peroxide wash or another antibacterial wash, and then marching upstream, if you will, from there, depending on what the particular lesions are. But But your observation, I think, is very consistent with what we've seen, and not just with capillary malformations on the face, more common locations, for instance, on nape of the neck, back of the head, for instance, below the direct back part of our head. So that's something, again, I think it ultimately is an individual measure of tolerance or lack thereof. And, and something, unfortunately, you kind of need to march forward with and see what's tolerated.
So it's okay to start with the average things that you would try over the counter.
Totally. I would totally do that. Yep.
Okay, thank you.
You're welcome.
Excellent. Oops, there's 2 messages here. Let's take a look. For neuro, for those of us whose kids do not have seizures, what is the current thinking of getting preemptive EEGs and considering prophylactic seizure medications?
So good afternoon, everybody. So I can tell you about what we have thought about pre-symptomatic approach to patients when we discover that they can have high risk for seizures. So the EEG, despite of several studies, did not prove to be a very good biomarker to indicate seizures for patients in Sturge-Weber with Sturge-Weber. The most important and I would say the only study that actually matter would be the brain MRI. And then we have some changes on the brain MRI that can indicate a high risk for seizures. And of course, the main risk, the main approach would be the first 2 years of life, right? So what our target how can I say, the target population to try to benefit from that kind of treatment would be the babies, to recognize the high-risk babies, see how would be the risk for having, because we know that the seizure onset matters for prognosis. And then we look into those findings on the MRI, and this has been the overall idea. We don't have at this point in time a very how can I say, a guideline written like in stone, like this is what everybody should do. Every case should be seen and discussed, right, with the provider. So because we have to put all the situation together. Yeah. And we are looking very, very actively into that, into options for intervention. Who are the babies that could benefit for treatment? What would be the best treatment? So this is a very active area of research and interest. Hope I answered the question.
I think so, Anna. That's great. Thank you. There's another neurology question. Is it typical to see some degeneration of executive function skills as people with SWS are adults?
Let me just see here. So is that for neurology again? I got a little distracted. Sorry.
That's okay. Yes, it says for neurology. It says, is it typical to see some degeneration of executive functioning skills as people with SWS are adults? I guess as they proceed.
Yeah, they proceed, like transition age. Yes, the answer is yes. So executive function is primarily a function from the frontal lobe. We know that some patients, it depends on the extension, and if they have neurological involvement associated with the Sturge-Weber, they have the tendencies to have that kind of alteration, cognitive issues. Yes, the answer is yes. And then even without family history, the symptoms of ADHD is highly associated with the Sturge-Weber syndrome. Yes.
Thank you. For Dr. Levy, is there any correlation between capillary malformations on the skin affecting joints in the area of the birthmark?
Let me see if I understand the question. Are you talking about a capillary malformation or port wine on the face impacting joints, or port wine stain, for instance, capillary malformation overlying a joint impacting joint problems?
So it would be the latter. Our daughter has her entire face and then down her left shoulder, arm, back, and her whole hand. And we're just curious if that had any correlation to weakness in where the birthmark is predominantly at.
Gotcha. Well, I guess I'm going to answer it in two fashions and pass part of this to Dr. Pinto, but I would think, assume, and correct me if I'm wrong, I'm assuming that you're talking about the birthmark being birthmark and what's over the extremity on the same side of the body?
She actually has some bilaterally.
Gotcha. So I guess I'd look at it in two contexts. One is what you're seeing downstream, so to speak, a reflection of what's going on in the head. That's one. The other is just in terms of local impact on muscle, bone, joint. The answer is yes, that can be an issue. It's more typically seen, however, when you have, in addition to what you see on the surface, similarly differently formed larger vessels, in fact, that may be involving those deeper, again, muscle or bony structures. And I guess in that regard, if not already done, and again, I really would be interested in Dr. Pinto's comment on this, evaluating the potential of what's on the head and in the brain, for instance, affecting that. If that's not a reasonable consideration, then imaging, typically with MRI, with and without contrast of the affected limb, would answer for you what is deep to the surface and where, if present, it might be involved.
Okay. You answered so beautifully that I don't think I have much to add. You're absolutely right. Natalie, it's exactly right. Yeah.
And so if there is correlation there, are there things that we need to do preemptively? Like, do we need to explore more intense, like, occupational therapy to be sort of preemptive as she grows older? Or is it just sort of what's there is there and we deal with it? I don't know if that makes sense.
Well, yeah, it's clear what's there is there if there is something present, yes. However, as you've suggested occupational therapy, physical therapy helpful. This is an area, though, in medicine that is evolving when you talk about genetic basis of vascular malformations in this sense, and the potential impact of even systemic medicines to affect growth, and not uncommonly now with some, to decrease growth of vessels that are in fact present in certain areas. Again, it just depends on what is present and the broader context of how your kiddo looks.
And there are several associations with the Sturge-Weber with other diseases such as Kiplotrienone syndrome, and sometimes there are some involvement of the lymphatics. So, for example, to explore exactly what this vascular malformation is about, how deep it is, I think that is important, right?
No, it's terribly important. And, and when you talk about Kiplotrienone, for instance, and you can certainly have the clinical appearance of both that and Sturge-Weber, because they're developmentally, if you will, cousins, relatives. But again, newer drugs, and I think everyone here is probably aware of, at least in the past, and some people still using at the time of laser and follow-up to laser, topical sirolimus. People have used systemic sirolimus, in terms of trying to impact vessel growth, if you will, expansion. But there are newer agents that are, called PIK3CA inhibitors that hit another pathway and absolutely have been helpful, specifically in some patients with Kiplotrienone, that phenotype, that appearance of an individual. So where do you live, may I ask?
We're in Indiana.
in Indianapolis.
Uh-huh.
Yeah. So, our colleagues there, I really think should be able to help counsel you in this regard. And again, as you've heard with the other speakers, I think any of us would be happy to, if you will, discuss this offline.
Okay, so which we have lots of specialists. Which one, I guess, would this fall under? Because we have endocrinology, because we had some concern about her growth, because she's very tiny. And so we just, I guess I don't know which specialist it would really, who we start.
Well, I mean, if I'm embarrassed to tell you, I don't know, are you at Riley Children's?
We are, yes.
Yeah. So I don't know specifically if they have a vascular anomalies group. I mean, like, at Boston, like we had in Houston, like we have here, where you've got, dermatology, hematology, people in very different disciplines who can really put their heads together and help evaluate a problem such as you're describing, and then decide whether, a medical or some other type of management option might be useful. That's if they don't have that, and I'll tell you what I might do while we're talking is text a friend of mine who runs the service there and see if there is such a group or not.
Yeah,
so Megan, the name of those groups, typically they are called like vascular anomaly clinic, as exactly with this multidisciplinary group. And I know, for example, here in Boston, people accept records for second opinion online. So, for example, if you send all the material, they would evaluate everything, so all the specialties can comment, and then they can mention about what, if it's worth it for you to come to one of those centers, if that's so, what they could contribute for the care. So sometimes to consider that, collect all the records and put it on the vascular anomaly clinic kind of, multidisciplinary group.
Perfect. That would sound great. So I think I don't want to take anybody else's time. So I might just touch base with Julia and we can kind of figure out next steps. And then that way we can get to others' questions. But thank you so much for that, that answer and insight, because I'm very excited to get her to a group approach to this.
No, I think that's totally appropriate.
Yeah.
Thank you so much.
Thanks, Megan. And I was just going to say, we'll talk Monday.
Perfect.
Yay. Now, I did have one question that came by the registration. Catherine Lynn, I know you had asked about some voiceover and some different commands for Kristen. Did you get what you needed from that training? And if so, if not, we can send you some of those links too. I just want to make sure you got what you needed. Uh-oh, she might not have heard me. We'll come back to you.
She said, what did she ask?
Oh, she had asked about some commands to write emails on an iPad. From that perspective, from the assisted technology side.
Oh, no, I don't think we got that.
Okay. I have your email, so we will go ahead and get that for you.
Okay, thank you.
You're welcome. And then Heather writes, for dermatology, should there be any difference in treating eczema on port wine stains? Her 3-year-old has a lot on his port wine stain, but I'm afraid of overusing topical steroids. And there's, Dr. Levy, there's actually 2 questions about it. There's a second one that came in. Similar question as eczema above, only on port wine stain eyelid, hydrocortisone works, but it always comes back. Daughter uses makeup, but only port wine stain eyelid, impacted by recurring redness and itchiness.
Gotcha. Well, I mean, again, as I mentioned with the first question I had about the acne, in terms of the skin at the site of the capillary malformations, it inherently tends to have, if you will, more dryness and more potential for irritation. So, you cannot over moisturize in terms of frequency. So that's something that is part of life going forward. And and cannot be stopped. And then if you're, for instance, it's not surprising that the hydrocortisone is useful, but if you're finding that you need to use it, basically on an everyday everyday frequency, there are actually 3 non-steroid based anti-inflammatories that would be totally okay to use on a more frequent basis at, if you will, sensitive skin sites as the eyelids are. And then the other thing is, and I'm not suggesting this is a reason for laser at all, historically, some of the patients, when the birthmark itself improves with laser, will see less, but not absence of the problem you're talking about at this point. So, I guess if, as I tell my patients so often, if this were my child, I guess at my age, hopefully only grandchild, I would say frequent emollient, grease of choice, and then finding an anti-inflammatory that can be used, if need be, safely on a daily basis. That would likely be a non-steroid based one, or using, sometimes we'll use actually something more potent than plain hydrocortisone, but just using it a couple of times a week, for instance. And that's something you can negotiate with your dermatologist or pediatrician or family physician, I would imagine.
Thank you so much. And it looks like we have one for neurology. My 35-year-old daughter was diagnosed with the Sturge-Weber Syndrome and familiar Mediterranean fever last year. She is currently averaging 20 days a month with fevers over 101. Her last MRI indicates more blood vessel clusters than the previous. Are the fevers contributing to the seizures, and do more clusters of blood vessels unusual?
So, for example, we know that for everybody with epilepsy or conditions related to seizures, in most so Sturge-Weber, whenever you are sick, you can have exacerbation of your neurological symptoms. Let's put like that. But epilepsy certainly. So by being sick, she could have more of it's almost like you put your body more into stress mode, and then this can exacerbate seizures, unfortunately. In Sturge-Weber patients, they are more vulnerable to illness. So I'm really sorry to hear that she's going through a hard time trying to control 2 rare diseases and one potentially influence the other. And then, for example, the Sturge-Weber, particularly from the brain perspective, it's not a proliferative disease. Nobody ever proved that. And in adult phase, we're not expecting vessels to be increased. That could be something else. And I think it's very hard for us to comment. I can tell you in general that there would not be expected increase of vasculature in the brain, because it's not a proliferative disease. Like I don't know if I'm using words that could be. So it is it's like they don't keep like reproducing. Like they are stable. They have more other circulations, but they don't create more vessels. I put like that. I think it's yeah. That's what I'm trying to say. I hope I answer your question, and I hope she's on aspirin too.
But those are all the questions we've had in the box, and we're almost up to the 3 o'clock hour. I feel really bad right now, Dr. Fauch, because we didn't ask you any questions on the research of ophthalmology, but we are excited to see you in Texas as well. So, but if no one has any other questions, I'll let you go at 3 o'clock. And thank you all for coming and for attending. And thank you to Dr. Fauch, Dr. Pinto, Dr. Levy, and Kristen for hanging out with us this afternoon and answering some questions. Thanks, everybody. Bye-bye.
Bye.